focus on the double kiss crush technique. A timestamp today is the 12th March 2021 on the Friday, 3 p.m. in Singapore. This event is organized by the APSC, endorsed by the Singapore Cardiac Society, as well as EBAC for CME accreditation, kindly supported by Sengkang General Hospital in proud collaboration with Medtronic. My name is Jack, the current president of the Asian Pacific Society of Cardiology and the president for the International Society of Cardiovascular Pharmacotherapy. I'm an interventional cardiologist based out of Singapore. And we're very happy that today's fourth live workshop is hosted out of Sengkang General Hospital, the latest general hospital in Singapore. We're also very happy to have our usual spread of speakers. To start the session going with Professor Tan Hui Cheem, Senior Consultant, Department of Cardiology, National University Heart Center. He's going to speak to us on bifurcation techniques, the when, where, and how of it. Dr. Fahim is then going to follow up with a lecture on the potpourri of burning bifurcation questions that fellows commonly ask when performing bifurcations. Our live operators today will be Professor Aaron Wong, the head of cardiology at National Heart Center Singapore, assisted by Prof. Chin Chitang, and his brother, Dr. Chin Chi Yang, is going to be narrating on the OCT imaging for this case. Panelists, we have Prof. Murasato from Kyushu Medical Center, Japan, Prof. Zhang Junjie from Nanjing First Hospital, China. We have Prof. Natawut from Mahidol University, Thailand, Dr. Liu Haobang from Sabah Queen Elizabeth II Hospital from Malaysia. And we have one of our fellows couldn't make it, so Professor John Yap has kindly agreed to be our live fellow stand-in. And he, together with Dr. Wong Ning Yen, has pre-recorded quite a few bifurcation bench top models. Our coordinator for today, with great thanks, will be Dr. Ke Yen San. Our live fellows today will be Dr. Wan Fazal bin Wan Rami Shah from IJN. Dr. Eric Jong calls in his apologies. This webinar is copyrighted by the APSC and should not be distributed without the prior permission of the APSC. The views and opinions expressed on the webinars are those of the faculty members and do not necessarily represent those of the APSC. A bit on housekeeping, the current live content is made available via Wonder Medicine, the APSC Facebook and YouTube pages. For Singapore registered physicians, CME points will be submitted for attendees who are connected throughout the whole duration of this webinar. EBAC grants CME points for attendees who attend the full session. For the rest of the regional attendees, you will receive your certificate of attendance upon completing a survey sent by email post-webinar. For attendees calling in live, please type in your questions you will have in the Q&A button, and we'll try to answer all the questions submitted. A pitch for upcoming webinars for APSC. 18 March, we have a session on protecting AI patients with diabetes beyond stroke prevention. On the 16th April, on a Friday, we have a follow-up session on fellows teaching course Save a Life, narrated by Professor Tan Hui Cheem. This time, we're going to do unusual coronary anomalies. Let's focus on today's learning objectives for fellows. We have fellows focus. One, we want to narrate the ideal patient that should and can have a successful bifurcation PCI. Two, we want to go through the step-by-step guide to learning double kiss crush technique in bifurcation stenting. We want to improve the understanding and avoid pitfalls when performing two-stent bifurcation PCI. Fourthly, we want to understand how to use OCT suitably for bifurcation stenting. And lastly, we want to understand and review the current evidence and guidelines behind bifurcation stenting. So let's get started and get right to it. Without further ado, we'll invite Professor Tan Hui Cheem to give his opening lecture. Thanks, Prof.
Thank you very much, Jack, for the kind invitation. The topics that I'm being assigned to today is bifurcation techniques, when, where, and how. So I think PCI of bifurcation lesions require several technical considerations. The foremost of which is, of course, the discrepancy between the main vessel and oftentimes the distal vessels. And also the other considerations will include whether the side branch will remain patent, the plaque distribution pattern, the lesion composition, the angle between the main vessel and the side branch, and the location of the affected vessel. The PCI or bifurcation lesions also present itself with some unique complications, and the foremost complications that we're concerned with is oftentimes the plaque shift or coronal shift resulting in side branch closure. Less commonly will be dissections or perforations and so forth. So when we do a performance of a bifurcation PCI, there are three choices or strategies with regard to preservation of side branch. Number one is either to keep just the side branch open. Number two is a provisional stenting approach. And number three is a two-stent strategy. So when we say keep it open, we just merely want to keep the side branch lesions. Oftentimes it's because the side branch has osteo or diffuse disease and it's just too small for stenting or clinically not relevant, but it's something that we really don't want to lose it as well and causing an enzymes bump. So the strategy here, oftentimes we can just do with a 6 French guiding catheter. You wire both branches, you dilate the main vessel if needed, then you stent the main vessel and you leave the wire in the side branch and you finish off with a post-dilatation of the main branch with the jailed wire in side branch. So this is a keep it open strategy. If you want to make it a little bit more sophisticated, one can consider a jailbone balloon technique, of which you have a conventional jailbone balloon technique versus that of a modified jailbone balloon technique. So conventional is the one where you have the balloon straddling across the main vessel, side branch ostium into the main vessel. But when you have a modified jailbone balloon technique, the balloon pretty much just stay at the ostium of the side branch in itself and extending into the side branch, so without going into the main vessel. So this is another good technique of preserving the side branch and just keep it open. The second strategy that we are commonly familiar with is the provisional stenting approach. This is a strategy where you will adopt when you have a side branch oftentimes has minimal disease, or you have disease only on the ostium, and the side branch is also possibly suitable for stenting, but you will not do the stenting in the very first instance. So the technique here in the step-by-step approach is you insert a wire into both the main vessel as well as the distal branches. Then you stent the main vessel with a diameter selected according to the distal main diameter. Then you do a proximal optimization technique with a short balloon with a diameter adapted to the proximal main diameter. And then you do a guide wire exchange to allow for kissing balloon inflations. Now, you could very much just stop at the step 3 here if you do not intend to do a kissing balloon inflation. But if you decide to do that, then one can just simply do a guide wire exchange, withdraw the the jailed balloon, jailed wire, and then finishing off with a kissing balloon inflation. Now, provisional stenting approach is favored in the situations where you, again, insignificant stenosis at the osteo left circumflex, or you have a relatively small circumflex diameter 2.5 in the distal left main bifurcation, or you can have a wide angle between the LAD and circ and so forth. But what I will just comment here is that the provisional stenting approach is simple and fast, is associated with excellent short-term and long-term results as well. And some study may even suggest that it's got a better long-term mortality in the earlier years. It reserves all the other options in ease of when in case of failure. And actually, in most of the left main bifurcation, you can get away in 60% of the time with a provisional stenting approach. Now, how often do we actually need a build-up stenting in a provisional approach? It depends on what sort of studies you're looking at. In the earlier study by Colombo, looking at the red column here, there's a high level of a crossover to a two-stenting approach. But when you look at Japan as well as the Stegen's series, you find that the crossover is actually very low. So it all depends on what is your threshold as well as your indications for crossover to a two-stent strategy. What I would say is that when you have a following situation, perhaps a side branch stenting is warranted. When there is significant side branch flow impairment, TIMI flow of grade less than 3, or when you have in the presence of a major side branch dissection with a risk of abrupt closure, or when you have a significant residual ischemia, or when future access towards the side branch may be very important in that particular lesion. So this is the situations where you will consider a side branch stenting. And when you want to do a side branch bailout stenting, there are actually many approaches you can do. The cartoon tells you the techniques of TAP, reverse crush, and keloid technique. So you actually have access to all the different two stent strategies that you are familiar with in a provisional stenting approach, all of which has its own attendant advantages as well as disadvantages. What I want to highlight here is that some of the important techniques in the provisional stent approach is that you need to observe a port technique here, which is really a optimization of the underexpanded stent in the proximal main vessel. It helps to restore the proximal main vessel circularity. It facilitates the side branch rewiring as well as ensure a scaffolding of the side branch ostium. And the technique of performing POT is to select a balloon where your inflations of the balloon is right at the marker. So the shoulder of the balloon inflation preferably should be at the marker level. So you will position the distal marker right at the carotid junction to ensure that you have a proper expansions of the main vessel stent. Another some of the comments of kissing balloon inflations that can follows a provisional stenting approach is that you want to choose a kissing balloon of size that is similar to that of a side branch, and preferably a non-compliant balloon. And oftentimes we will just park the kissing balloons right at the carotid area and finish off with a larger proximal balloon for the port technique. Now, the third strategy here is, of course, the two-stent strategy. And double stenting is probably needed between 15 to 35% of patients to achieve an optimal angiographic results. And it's oftentimes considered when the side branch is of significant size, defined as more than 2.5 millimeter with a significant stenosis of a significant length. Most of the time, the technical strategy of a two-stent approach requires one to tackle the side branch first, just so that you can facilitate subsequent entry into the main vessel. And these are the commonly employed two-stent techniques that we know of. Keloid technique requires the side branch to be somewhat similar in size to the main vessel with a relatively wide angle, and it can be used as a suitable technique. But when you have a side branch and the main vessel of a significant size, perhaps a T-stenting or DK crush technique will be useful in this sort of anatomy. So the strategy of a two-stent strategy is basically very dependent on the bifurcation lesion. When you have a bifurcation angle of more than 70, perhaps a TAP or TEAS technique may be more appropriate. And when you have an angle of less than 70, perhaps a keloid or crush or DK crush may be a better technique. So TAP technique is something, or T-stenting, that is something that we employ. So essentially what you do here is that T-stenting is used to optimize side branch when you use a provisional stenting approach. We like to do a TAP technique here, particularly for Y-shaped angulation, but if a patient has clearly a wide angle, then perhaps a T-stent technique is good enough. So we also want to emphasize that the side branch access is oftentimes encouraged through a distal strut in order to have an adequate osteo side branch coverage. But in addition to T-stenting approach, a commonly employed technique is actually a TAP approach. And this TAP approach is a modification of the existing one. Basically, you have a stent across the main vessel, then you balloon the side branch, then you take a stent and position it with a little bit of a protrusion into the main vessel, and you do a kissing balloon inflation using a balloon as well as a stent balloons across. And you find that in this particular technique of TAP, oftentimes there is no side branch crushing at all and so forth. So you have a pretty nice, nicely created carina in this TAP technique. So this is a technique that is favored a lot by our European colleagues. Now, when you talk about keloid technique, this is again something that most of us are very familiar with. It was first described by Chevalier way back in 1998. It allows for adequate osteo coverage of both the main vessel or both the distal vessel. The thing about this technique is that the proximal vessel to the bifurcation have a double layer sleeve of stents. And the proximal ends of both main vessel and side branch stents need to be sized up to the proximal vessels. And so one requires the main vessel as well as the side branches to be somewhat similar in the diameter. And the advantage of keloid stenting is that it's suitable for all angles of bifurcation and provides a near perfect coverage of the side branch ostium. But the disadvantage of a keloid stenting is that there's a high concentration of metal with double stent layer at the carina and in the proximal part of bifurcation. A rewiring of both branches is required, but sometimes it can be difficult and time consuming. And we need to have both stents to accommodate the potential diameter mismatch between the side branch and the proximal main vessel. DK crush, which is what we're going to be focusing on today, is a 7-step technique which Dr. Zhang Junjie has shared these slides with me before. And this is something that we'll probably will go through in greater details. But suffice to say, the advantage of DK crush over the rest of the other techniques, it is proven to be highly effective for complex left main bifurcation lesions with large dominant disease vessel circumflex. One of the things is that it preserves the coronary anatomy. The ostium of the daughter vessels will be adequately covered, and the side branch access is ensured, unlike a classic crush. And one more advantage of DK crush is that the wire through the main vessel is preserved throughout the procedure, so you have no chance of losing access to the main vessel. The disadvantage of a DK crush is that it cannot be performed as a provisional stenting approach, and it requires multiple steps, and few operators have such experience with this somewhat multi-steps of procedure. The thing about DK crush versus keloid stenting technique is that some of the trials shows that DK crush is superior to keloid in terms of long-term outcome results. And this may perhaps be explained by the residual Neckim rings that we sometimes see at the ostium of the main branches in the keloid technique, which is not seen in a DK crush technique. So all this still need to be verified. But in deciding which two-stent approach, I like this algorithm. You can look at it based on the anatomy. If you think you can assess the side branch easily, then you can go on to subsequent technique. But if you think you cannot, then the best is to just do DK crush. If you can assess the side branch and the angle is more than 70 degrees, you can consider T-stent. But if the angle is less than 70 degrees, then I want to see the size of the main and the side branch vessel. If the size is pretty much the same, you can do a keloid. If it's not the same, a TAP or a DK crush will be better. So this is a algorithm that you may consider using. But one of the things that I have learned from the recent literature is that in deciding whether to do a one-stent or two-stent technique is really dependent on the complexity of the side branch disease that we are dealing with. And this is the definition criteria that Zhang Junjie and his center have given the world of interventional cardiology something to go by. So the criteria for definition of a complex side branch requires one to have one of these major criteria plus any of these two minor criteria. Once you fulfill this criteria, one should consider a two-stent approach right from the very outset. And we do have evidence like the definition tool to tell us that the clinical endpoints for complex lesion using two-stent strategy is much better than a one-stent approach here based on the target lesion revascularization, MI, and target lesion failure. So in conclusion, Mr. Chairman, ladies and gentlemen, I think the goal of PCI in bifurcation lesion is to attain optimal results in the main vessel and maintain a physiologic patency of the side branch. The planning of the strategy upfront is critical, and knowledge of all possible build-up techniques must be kept in mind. But I think as far as most operators is concerned, just knowing one or two-stent strategy is probably good enough. While the provisional side branch stenting should be the default strategy for low-risk bifurcation, perhaps a two-stent techniques may be preferable for high-risk or true bifurcation lesions. And although evidence is lacking as to the superiority of one two-stent technique versus others, I do feel that personally that any single two-stent strategy will be just as good, and if it's well employed and performed meticulously by an experienced operator. Thank you very much for your attention.
Thanks, Prof. Again, another amazing lecture. You covered tons of ground in 10-15 minutes. So now we have about 10 minutes to discuss around this opening lecture. So I would like to ask first Jonathan Yap. Sorry, you're representing all the fellows' questions here. John, can you give us a hint of when you fellows do bifurcation PCI, what's your main concern or fear?
Okay, Alan. So I think a few folds, a few things that we think about, every time we do bifurcations is, number one is, will we lose access to any of the branches, either the main or the side branch, and would we be able to rewire it? So that's one main fear that I think as fellows we had. And the other thing is how familiar we are with a particular strategy as well. Like some of these bifurcation techniques have multiple steps, and if you don't do it frequently enough at the start, you may actually have difficulty remembering some of the steps.
So can I ask you as a fellow, right? I mean, it depends on where you're trained, but what do you think is the easiest technique or the best technique to master as a fellow? Or should you know all techniques when you're starting out?
For myself personally, when I first started out, I thought that it would be good to at least learn two techniques pretty well. And for me, the two that I was most familiar with at that time, for two-stent strategy at least, was the DK crush as well as the Keloid. But I guess it varies from person to person. Looking back, probably a good strategy, a good armamentarium of techniques to have would probably be, you should learn a TAP, because that can help you bail out from a provisional strategy, and maybe either a DK crush or Keloid. So at least you have two in your skill set.
Before we go to Professor Zhang's comments, can I ask Fahim, what is your advice to fellows? Or is there any particular two-stent strategy you should master?
Well, I think it's important for fellows to get facile with one or two techniques and adopt a technique that they get the most training in. I think that's the most important thing. So if the lab they're training in is great at DK crush, then get facile with DK crush. If it's Keloid, then get facile with that. And then keep doing it again and again, and you become really good at it, rather than trying to master everything. And the other thing I would say is that fellows need to learn how to do a good provisional, because a large chunk of bifurcations can and perhaps should be addressed provisionally.
Thanks, Fahim. Can I check back with Professor Zhang now? I think Cheem did highlight a point nowadays saying that complex bifurcation will definitely benefit from a two-stent versus one-stent. Perhaps you can speak to that in a bit more detail for the fellows wise about what constitutes a complex bifurcation that deserves to have two stents up front.
Yeah, I think it's very important. Before make a decision for the individual bifurcation stenting technique, I think the most important thing should know the complexity of the anatomy. According to our DK crush trial, it's a prospective registration. Professor Shaoliang set up the criteria of the complexity of the bifurcation lesions. For big side branch, the vessel size, side branch vessel size larger than 2.5, with a lesion length more than 10 millimeter, with significant lesions. For this kind of lesions, we can classify as complex pipe lesions. According to the definition criteria, we can show the result compared with provisional stenting, two-stent technique, either crush, DK crush, or Keloid stenting were superior to provisional stenting in terms of cardio deaths and TR and 1 year result. So after definition criteria, we designed the definition 2 trial. Actually, the result published last year, Europe PCI. This is a randomized study. We enrolled 660 complex bifurcation lesion patients, randomized either to provisional stenting or to two-stent technique. Majority two-stent technique, 78% treated with DK crush at 1 year result. Shows compared with provisional stenting, two-stent technique was associated with a significantly lower rate of TRF, which was mainly driven by a low rate of TR and TVMI. So accordingly, so I think for complex bifurcation lesions, two-stent technique, especially DK crush, were superior to provisional stenting. Of course, DK crush is a complex technique which need a learning curve. So personally, I think if for young fellows, the first thing we should grasp the the provisional stenting, then we can step by step to learn how to perform properly the DK crush. Thank you.
Thanks, Prof. Chang. I would like Hui Chin to take this series of questions dialing in the Q&A box. So I see some similar questions. First one is by Sarab. Is it obliged to do a kissing after initial port in left main LED provisional stenting if you are stenting a provisional approach?
So the data for routine kissing balloon inflations in the provisional stent approach is not clear. So there are studies to suggest it's not, but there's certainly Nordic 3 and 4 tells us it's not very useful here. So I think it all depends on the individual assessment of the lesions by the operator at the end of a provisional stenting approach across the main vessel. If you think that the side branch access is very important for subsequent intervention or for the patient's prognosis, if there's a risk of dissection, or if there is a risk that you think that maybe flow is not so good, then perhaps you will consider routine inflation. But otherwise, most of the time I'll just leave it alone.
So just a port and selective kissing in the left main position. Any other views on this that's different? If not, we go to the next question by Dr. Anand. And if you do have a complex bifurcation that is calcified, what is your advice for a calcified lesion? Do you debulk it, or is there any difference in approach or technique? Prof. Tan?
This is where I think imaging is going to be very helpful here. I need to know what sort of calcification pattern that I'm dealing with. Is this concentric, eccentric, and so forth? And I think that if the lesions is severely calcified, some form of lesion preparations in the form of atherectomy or shortwave lithotripsis will be very important in terms of ensuring the success of particularly a distal left main bifurcation lesion. So commonly now we are seeing a lot of very complex distal left main. And I think that this is where imaging will help. And if you don't have imaging in your particular center, I would actually err on the side of caution and prepare the lesions with some form of atherectomy if you have nothing to guide you by.
So Prof, last comment from Prof. Murasato. In terms of imaging, can you give the fellows some rough idea about when you do imaging, how do you use that to assess for need for two stent and differences in techniques?
Yes, thank you. For the imaging guidance, the accurate measurement of the bifurcated site is very important. So pre-PCI imaging for the main vessel and the side branch is very important, and appropriate port size and stent size and appropriate port size and the side branch stent or balloon size selection is very important. And finally, we perform the kissing balloon inflation or port, and the apposition, stent apposition and the stent dilation area measurement is very important. And OCT has an accurate assessment of the guideway recrossing point for the side branch. That is very important. According to our 3D OCT bifurcation registry data, link connection, stent link connection is important, have a great effect on the stent side branch dilation. So if the link connection has located at the side branch ostium area, the side branch dilation is not great, is not so enough. So such kind of position, high pressure ballooning or the more aggressive port is necessary.
So my message to fellows with regard to imaging is that pre-PCI imaging helps you in terms of guidance of strategy. Post-PCI imaging to assess the results of your PCI, and that will obviously enhance the safety and efficacy.
Thanks, Prof. Just two last questions since it was asked. Can I get Natterwood to comment?
Yeah, may I add on with the imaging with the bifurcation? I think one thing with the definite vessel size that we get from main vessels and the branch vessels is important, but also with the plaque characteristic. I think with the fellow asking about the side branch occlusion, I think they have some imaging that you can tell from the side branch plaque characteristic that have like a bit lipid-rich plaque, or you have the carina that eyebrow size that may be high risk for the side branch occlusion, and that when you need like more two stent technique. And also important with the when you with the calcification, I think if you need to prep, how much you can prep and what device, I think that are important. And also with the using the strategy, if you want to use the provisional, as Dr. Tan have been said, we have to cross the distal. And if you want to use the decay crush, you have to cross the proximal. And I think the imaging with OCT, you can clearly see where the point that why clotting side branch. Thank you.
So we'll try to demonstrate all that in our live case in a bit. So can I get Professor Tan Hui Cheem to take one last question from Dr. Hasru? It's about your take on bifurcation Keloid technique, saying that the main and side should be similar size. But his question is that since most stents can be post-dilated or overexpanded, for example, a 2.5 can go up to 2.75 with a Zymes, do you necessarily need to have similar size vessels to do Keloid?
So I think that if the discrepancy becomes too huge, like a 2.5 vessel in a side branch and a 4.0 in a main vessel, no good stents can be stretched to that sort of degree. So I would suggest that if you have such great discrepancy, a decay crush is a better technique here. Say, for example, if you take a synergy or Medtronic stent, I don't think you expect a 2.5 to go up to a 4.0 and above for most of the second generations DES.
But 2.5 and a 3.5 is okay, you think?
Yeah, so 2.5 to a 3.5 is good. So it all depends on the discrepancy that we are dealing with here.
So maybe one
other option is I think if you have like much discrepancy with the stents, I think some dedicated stents like Stentis, I think you can use that. But I think for the fellows, I think familiar with like a decay crush technique, I think is most important here.
So Fahim, do you want to take the last question before we move on to a live case? What is your advice on stent and the DEB as a professional technique? We are kissing with a DEB.
Yeah, so it's not been systematically very well studied, but anecdotally, I mean, the individual experience has been fairly robust with that. So in other words, you balloon the side branch and then treat it with a DCB. The important thing is that in the side branch, you have to get a very good residual, which is kind of less than 40%, and that's often not so easy. So if it's a large side branch and the patient is otherwise suitable for a two-stent technique in terms of DAPT and those kind of things, I would still favor two-stent strategy. But if it is a useful alternative strategy when putting in a second stent in the side branch is not feasible, either technically or based on patient characteristics.
Thanks, Fahim. So, Obi-Wan, can we move on to the Cath Lab now?
We're live, are we?
Yeah, you're live.
Jack, can you hear us?
Yeah, I can hear you. I'm just going to stop my screen share now so we can just see you before I share the case again. So, Obi-Wan, can you share cam 1? So, you want to say hello to everyone before I share the PowerPoint again?
Yeah, sure. Hi everyone. Welcome to Singapore Sengkang Hospital. My name is Aaron Wong and my colleague Chiteng are going to do a bifurcation case today. So Jack, can you show the PowerPoint slides? I'll just present the history briefly. Yeah. So this is
I hope you can see the PowerPoint. You just let me know.
Yeah. We can see. Yeah, correct. Yeah, it's a 63-year-old gentleman with the risk factors of diabetes, hypertension, hyperlipidemia. Actually, not much of a symptoms of angina, but was investigated for symptomatic PAC and a bit of hypertension urgency. And during the examination investigation, we found that there was a regional wall motion abnormality. And actually, this was done last year, January, and showed that there's a left dominant system with double vessel disease. And we sort of discussed the options of bypass, but the patient declined. But still to some delay in sort of revascularization. So the patient came back almost a year later for revascularization. So we are a bit anxious actually just now when we did the angiogram that we're not sure what it will become. It could be a CTO CTO clot. Yeah. So so can you just show the initial angiogram? It's quite a funny, interesting anatomy actually. It has it's a left dominant system, and then there is a quite long mid-LAD disease with a very tight diagonal. Actually, it's a branch diagonal. The two branches, one came out very early of the diagonal, very tight lesion, and the mid-LAD looks tight as well. And then there's an aneurysm in the mid-circ, and then a few branches. OM branches has some disease as well. So, yep. So the target today is for the LAD diagonal bifurcation lesions. Yeah. So can we go live to the pictures?
Yeah, we can, but before we go on, and maybe you can show us a baseline angiogram, aerial cranial view.
Yes, sure. Yep.
Then we can have we'll ask the panel and the fellows to comment. Can you play, Aaron, if you don't mind?
Yep.
Sorry, John, you're the only fellow here, and we'll just get you to provide some quick comments. What will you do as a fellow here? Which technique do you think we can get away with? Can we just treat the diagonal, you think?
Next one.
We need to treat the LED. If John is not available, can I get a comment from...
yeah,
John?
Sorry, I was just waiting to see the whole angiographic images.
Yeah.
Next one.
Okay, so...
It's not so good. Next one.
I mean, there's a possibility that we can get away with just doing the diagonal, but I think, if we have imaging, it will really help us to see what's happening in the LED portion distal to the bifurcation. But, at least from this view where it's frozen now, I think it's probably diseased. I think a two-stent strategy will probably be more ideal.
So I want to come back to Professor Zhang's inputs just now about a two-stent upfront strategy for complex bifurcation. Do you think this fulfills the criteria for complex bifurcation? Professor Zhang, please.
Yeah, I think from the baseline angiogram, it's a typical, I think, complex bifurcation lesions according to the definition criteria. First, I think the side branch is larger than 2.5. And also the narrowing of stenosis at the side branch is critical. And also the lesion length is more than 10 millimeter. It's a major criteria. In terms of two minor criteria, I think the first, the distal bifurcation angle less than 45 degrees. This is first minor criteria. Second is main vessel lesion length is longer than 25 millimeter. So one major criteria and two minor criteria. I think it belongs to complex bifurcation lesions.
And should I ask you what bifurcation two-stent technique you recommend?
DK crush. If I treated, I will use a DK crush technique.
Thanks for that, Prof. Zhang. Professor Tan, your opinion about...
One comment here. Can you hear me?
Yes, Aaron.
Can you hear
Go
me?
ahead.
Yeah. So this actually is the LAD just after the diagonal doesn't look like there is a from certain view doesn't look so tight. Some people may say just get away with the mid-LAD stenting, but the aerial cranial view show that there is disease at there. So we have decided for a DK crush, but this one actually is a 011 lesion actually. So the proximal LAD have no lesions. Yeah, we decide for also. I mean, this is a crush, a DK crush technique for this one. Yeah.
Thanks, Cheem. Any difference in opinion?
No, actually, I kind of concur with Zhang Junjie. I think this is a complex bifurcation lesion, and I think the LAD is significant beyond the bifurcation, and so I'll go for a DK crush here.
My opinion, it's a side branch diagonal branch is very important. I agree with it. However, the predilation was a 2.0 or 2.25 millimeter balloon. If we can get the large lumen, we treat the DCB for the side branch and then member cell stenting and provisional. Stenting is better. If the dissection is seriously occurred, there are two stent technique. DK crash. My favorite is the Keloid technique. So Keloid technique is performed.
Fahim, what do you think are the usual questions fellows ask here that you can address?
I think the obvious question fellows would ask, which has already been asked, is that how significant is the LAD? And I agree with Aaron and Huay that in most views it looks kind of on the moderate bordering on severe category. So I think one question that fellows would ask is that if they have the question, is it significant? Put a pressure wire. It's just simple. It'll take away all the ambiguity. The diag itself is large. It's very big, and it's not a diag you want to either compromise or lose. So I think if you're going to stent the LAD, then I think you need to stent the diagonal also.
Okay, so Aaron, we're going to move on to you, but the points taken is this, to just quickly summarize for the fellows. This fulfills the criteria of a complex bifurcation, and a lot of our panels think that a two-stent upfront strategy is a significant diagonal side branch. So I think it meets all the criteria. We're going to, and we also heard that we need more information with intravascular imaging. So maybe you can show us what you're going to do to achieve a best DK crush technique here.
Okay, Jack. So before we start about the OCT, so we actually use a 7 French system because it's a bifurcation lesion. You can do away with 6 French, but it'll be a bit tight because the wire may tangle and difficulties in putting 2 balloons in. So we actually use a glide sheath. A 7 French glide sheath actually is advantage that the external diameter actually is, outer diameter is only about the 6 French equivalent. Okay. So we use a 7 French EBU 3.5, and what we did is we wire both, and typically we use the radio opaque marker to measure the length. If it's a very long lesion, so it's more accurate. Yeah, next, yeah. So we estimate about 38, maybe 40, 38, 40. Yeah, next. So we wire both. This one, the diagonal probably about 30. Yeah, looking at the radio opaque area. Okay, so we did an OCT actually before we do any pre-dilatation. So Chiang.
You can see the OCT goes down very nicely.
Yeah.
Right. Okay. I presume everyone can hear me. So this is we'll just go through the OCT findings. So going from proximal to distal, this is the distal left main. Here at the 9 o'clock position, you see the circumflex. So anything else that goes further down the vessel, the 9 o'clock should be diagonals. The epicardium is here at the 12 o'clock area, and at the 6 o'clock area should be the myocardium. So anyway, so that's to orientate ourselves with the OCT. So this is in the ostial proximal LAD, relatively, disease-free, some fibrotic plaque, nothing very much. Here a little bit more plaque, a bit of lipid here in the 6 o'clock region, but otherwise the vessel is nice and big. So here is the slightly ectatic looking kind of segment just proximal to the diagonal branch. You still see 2 wires. You see the wire in the 11 o'clock position disappearing into the diagonal branch. So we're going to try and land proximal to that, obviously, because distal to the diagonal, there is disease as well. So here we distal to the diagonal, the 2 to 6 o'clock region. It's a low intensity kind of plaque with attenuation as well. So it's more suggestive of a lipid. This is at the minimum luminal area. The minimum luminal area is 1.83 millimeters square. So we didn't do FFR in this case, but with a minimal luminal area of 1.83, you would expect the FFR to be positive. So again, at this area, there's some eccentric plaque from at the superior part of the artery, and it looks like it's mainly lipidic plaque. So moving more distally, mainly fibrous lipidic plaque. Not a lot of calcium, so that hopefully helps us predict that we will be able to achieve relatively good pre-dilatations with normal balloons. This is the distal, what we expect to be the distal landing zone. So now doing our measurements here at the distal landing, the vessel diameter from EEM to EEM is about 3 millimeters. Moving more proximally now, the proximal landing zone, maybe somewhere around here, is considerably larger. If you look at the EEM to EEM, it's about 4.3 millimeters square. The length is it's almost 40 millimeters, so a little bit long. Not sure if we'll be able to fit 138 millimeter stent across the whole thing. If we can't, then we may have to use 2 stents in the LAD. But yeah, so in summary, the OCT findings of the LAD show that there is what looks like a critical lesion in the LAD with diffuse, mostly lipidic and fibrotic plaque. I just wanted to point out this branch point over here. If you look at the longitudinal view at the bottom of the screen, you can adjust the cut. So I've adjusted it to around about here. So you can see this is the diagonal here where I'm moving my arrow. I hope you can see that. If we measure the distance from the carina tip to the branch point, I've measured that to be about 1.6 millimeters. Studies have shown that if your branch point is 1.7 or less, then there's a higher chance of there being a side branch compromise. The carina tip angle, if it's less than 50 degrees, also is suggestive or predictive of side branch compromise with main branch stenting. Here, we don't have the facility to measure angles on this software, but just by eyeball, this maybe looks about 50-ish, 60 degrees. So it's kind of borderline. So I think this is when there's such a big diagonal and there's OCT findings suggestive that there might be side branch compromise, I think a 2-stent technique is probably quite prudent in this case. Thanks.
Thanks, Xiang. Did you guys do a OCT from the diagonal back, or is that necessary at all?
No, in this case, the operators did not perform an OCT in the diagonal branch. I guess that apart from length measurement and maybe assessment of the plaque, there's not much more to gain from an OCT of the side branch. Yeah, so it wasn't performed in this case.
Dr. Murasato, any comments from you regarding the OCT run or other teaching points?
Yeah, about the member cell, the explanation is perfect. So side branch compromise point is a bifurcation point. Bifurcation point length is less than. And the bifurcation cardinal angle is very important. However, side branch region is very tight. So I think the predilation is necessary to perform the side branch pullback. Side branch pullback is also important if you perform the 2-stent technique, predilation is necessary. After predilation, side branch pullback is necessary to for the appropriate size device size selection for the side branch. So in my Cath Lab laboratory, after predilation in the side branch, we perform the side branch.
Dr. Natawat,
yes. I would also, a couple of things I think is important for fellows. I think for sizing the vessel, I think when you're dealing with lipid, you might have difficulty finding the EOL. But on this case, sometimes you have to use the lumen. But for the lumen criteria, I think this EOL is better. In this case, you can define go to the distal, find the landing zone. And once you find the landing zone, you see the size of the vessel is 3.0. So that's good. And for the lens, I think if it's a good tip that if you don't have imaging, I will always use the Y as a marker for the lens. But if you have imaging, I always rely on imaging. And for the size of the lens of 38, I think when you putting 2-stent technique, I think you remember that you have to do pot. So I think you will need more than 1 stent because the lens is more than 38. And you remember the proximal, you have to pot the proximal afterward too. So depend on the size of the balloon. If you have the NC balloon of 6 or 8, then you might have to add on that to enough landing for the proximal part to potting. So I think a couple of things I think is important. And for the, if I open the imaging for pre-vessel assessment, I would also do the side branch imaging. So I can perfect sizing the vessel size and landing the length of the vessels. I think it's cost $1,000 US and you want to use it all, make it more all cost effective.
Make it worth your money. Prof. Tan, having seen the angio and the OCT, what would you predict Aaron would actually do to best optimize the DK crush technique here? What would be your sizing, your rough gauge on what he will be performing?
So I would imagine that he will go along with a two-stent strategy that he has already decided at the very outset, supported by now the findings. I would think that he will size it accordingly. I obviously will not size it exactly of the stent to the EEM, probably downsize by 0.25 and take it to the nearest diameter of the stent. So I would think that maybe it's like a 275 to a stent for the main vessel, at least as for the distal vessel, and then probably take a 3035 stent approximately. So you probably need two stents if we are looking at the residual onyx stents today. So a two-stent DK crush approach will be something that is very appropriate here.
Thanks. Aaron, we'll go back to you. Obi-Wan, can you switch to fluoroscopy and see where Aaron is at now? Aaron, you'd like to tell us what you have done so far? Obi-Wan, can you unmute Aaron?
After we did the OCT, we pre-dilate the diagonal. Yeah, you see the 2.0 balloon.
Yes.
Yeah, and then we use a 2.5 NC balloon to dilate the mid LAD part, and then we did a cine actually. Yeah. So this is the results. So actually, we decided for two stents technique. So we did not use a two, like Dr. Murasato suggested that we use a balloon to dilate, see whether got any dissection. Looks a bit hazy in the diagonal. Yeah. So we decided for a crush technique. So while you were discussing about the OCT, we actually placed a 2.25 stent in the diagonal, 2.25 So we position it just maybe about 3-4 millimeter of the stent actually come within the LAD. Yeah. So I think this is, yeah, next one. This is the final one. Yeah. So we deployed it. Yeah, it actually looks very big, 225. Yeah. So we thought it can take a 2.5, but we took a 225. Yeah. So we dilated a bit more, higher pressure, and then we crush it with a 3.0 NC balloon in the LAD. Yeah. And just a story here. Testing one. So we actually lose when we pull out the balloon. The wire actually came out actually. So we're a bit dangerous because the stent wasn't properly crushed, yeah. So it may wire into the stent struts. But with Seng's great skill, we actually rewire the LAD without any problems. Actually, the wire actually went into the diagonal actually. Yeah. Not sure whether it went into through the true stent strut rather than across the stent struts. Yeah. So we took it out and then we potted with a 3.5 short one. And then that's it. Now we are going to recross the...
Aaron, can I just pause you here? You go back to your last few shots. I'd like to ask Professor Zhang, in terms of the steps-wise for DK crush, what other steps would you have advised, or do you think there's something else that could have been done?
Yeah, I think for this particular case, actually it's a Medina 0112 bifurcation lesions. When do the DK crush? After side branch standing, when we use a mammoth balloon to crush, I think for this scenario, it's very important. We should use a two-step balloon crush. Just as Dr. Allen Zhu, the first is use a 3.0 balloon. 3.0 balloon is according to the distal mammoth size. Then, in order to fully crush the side branch stem protruding into the mammoth, we should select a big size balloon, which the size is according to the proximal reference mammoth. 3.5 balloon gets fully crushed. Then we can do the rewire the side branch. It's very important. Otherwise, if you cannot fully crush the stem protruding into the main vessel, you are when you rewire the side branch, you are easily put the wire into the stent lumen.
Professor Zhang, can I just clarify? You're saying that you should post-dilate the ostium or the diagonal with a 3O NC balloon first before you crush? Is that what you're saying?
It's also very important. If the side branch ostium is not fully deployed, we should post-dilate the side branch stem before we do the balloon crush. Yeah, it's also very important.
Yeah, that I also agree. Any other tips here, Fahim?
I think I'd just like to emphasize the point just made, that you do a crush with a smaller balloon and then you do a pot crush, which is, in this case, take a 3-5 and crush the proximal part of the stent so that you've got full crush before you then rewire. And then when you rewire, you're trying to make sure you get the proximal, or more importantly, a non-distal strut into the side branch.
One of the comments that I have here is that I know the side branch wire came out, but it will be useful to leave the side branch wire in place if possible, because your subsequent rewiring can use that as a marker to track into the proximal cell of that crushed stent. So for a DK crush technique, your rewiring should be of the wire of the side branch should be as close as to the marker wire. Whereas in a keloid, the rewiring of the wire should be as far as possible from that trap wire. And at this point in time, it's okay to leave the wire being trapped because there's only a very little bit of metal that is pressing on the proximal part of the wire. So there's no fear of the wire being trapped irretrievably.
I think there are quite a few good questions coming from the attendees. So I'm going to narrate them one by one in order of the steps here for people to answer. So Sarah asks, firstly, when you have a protrusion back to be crushed, how many mm or stent struts for the side branch stent should be protruding into the main branch to be crushed for optimized DK crush result? Professor Zhang, any guidance? Is it more like a tap? Is it more like halfway between classic and mini crush?
2 or 3 millimeter for me for DK crush. Side branch stent should protruding 2 or 3 meter into main vessel.
When you say 2 or 3 millimeter, is there a tip to say it's 2 or 3 millimeter? The balloon markers match the main branch balloon. How do you gauge that is 2 to 3 millimeters? Because what you don't want is to miss the ostium, right?
Yeah, if you're 2 millimole, you will sometimes miss ostium. So in order to fully cover the side branch ostium, I think at least 2 or 3 millimeter.
Any tips?
I think a rough rule of thumb is that the stent, the side branch stent marker should just touch the balloon that's in the main branch. Then that way you're sure that you're in the you've covered the ostium, but you're not too far in the main vessel.
Hao Bang, any tips on this?
And the stent kind of the stent is very important, especially the resolute stent, Onki stent has a helical core. So the proximal tip has a smaller cell. So the proximal cell wiring causes a cell expansion limitation. So the Onki stent or a synergy stent has a proximal cell is smaller than usual stent, usual strut. So the protruded length slightly longer than the usual stent. So 3 millimeter or more is better.
Okay, so that's also a good point. Can I, OB-Van, can you unmute Aaron? Aaron, can you tell us what's the advantage of using an Onyx stent here?
Oh, Onyx, beside the proven clinical efficacy, yeah, okay. Yeah, so the Onyx come with the different sizes of the stent. The expansion limit, there are 4 platforms actually, 2.0 to 2.5, 2.75 to 3.0, and then and they have the biggest stents 5.0 actually. So 2.0 stent actually can go up to about 3.25. So the stent expansion is quite good actually, yeah. And also the Onyx stent is what we call circular rather than compared to rectangular. So they say that it's easier to cross with the if we need to cross the stent strap, cross the stent with the balloon, it's less likely to catch, yeah. And also the side hole access is quite good. Even a 2.0 stent have a side hole access, side branch access of more than 3 millimeter.
Can you share with us what step are you at in the DK crush?
Yeah, okay. So Jack, we have a bit of problem here. So we did the crush, we crossed the side branch with the wire, but the 2.0 balloon cannot cross after the pot. And we use a 1.5. 1.5 also can't cross. So maybe we didn't cross proper stent straps. So we tried to use a balloon to put it side by side, do a stent boost to see whether the wire actually go through the stent or sideway of the stent. But again, the 3.0 balloon couldn't cross the thing, then the wire loose. So we're going to get a 2.0, this one 2.0, right? In the LED, just do a stent boost to see where the wire enter the diagonal. And
any help from the faculty?
It's also, I think it's a good point here too. If you have difficulty crossing, maybe you do OCT imaging to see where the wire crossing into the diagonal.
I totally agree with it. The OCT pullback from the LED clearly demonstrates the wire crossing point to the side branch. Maybe a wire crossing is some trap of the hoop of the thread.
Alternatively, you can pop it, port it even larger with a balloon, higher pressure.
Yeah, from stent boost, I think maybe the stent is not fully crushed. As this scenario, I think OCT we can check it from the main vessel to see what happened.
So Aaron, I think this is not a real good example, I said, for fellows. I think the advantage of DK crush is that the main branch wire stays intact, I guess. And in this case, I think the main branch wire came back and forth. It could be that your main branch wire could have crossed part of the stent even. I'm not certain. Are
you able to advance the balloon across into the LED?
It looks like the side branch is go through the stent, not sort of through the crush. So we're going to use a 3.0 to crush the, try to crush the stent again. And a new 3.0, just now the 3.0 is a used balloon. So we see whether I can crush it a bit better so that when we recross the side branch, we can cross it at the proper stent strap rather than through the stent, yeah?
Actually, a balloon failure to cross into the side branch is quite common even with a DK crush. So this is a good demonstrations of what you can do. So you port it again, and then after which you can try to use even anchor balloon in the main vessel to facilitate your side branch balloon entry.
So
yeah, there's lots of ways to build yourself out, Aaron, and I think recrushing it, figuring out whether you are correctly placed in terms whether through OCT or stent boost is a good idea. So we're going to allow you to just finish up here over the next 10 minutes, and then we'll come back to us the steps for fellows. I'm going to just take a pause here to break into the second lecture by Fahim, where he's going to answer a potpourri of common fellows questions. So Fahim, if you may give your lecture.
Sure. Let me try to share my screen. So are you able to see my slides and hear my voice?
Yeah, very clear. Go ahead.
Okay, great. Well, thank you, Jack, for inviting me to give this talk. And certainly, this is an interesting and very challenging case that Aaron is doing. And I think for fellows, no case is too simple, and every case can be challenging. So my job is in the next 10 minutes is to sort of go over a potpourri of burning question. So a lot of what you're going to hear right now is what you've already heard, both in the discussion and from the excellent talk by Huay Cheem. So, repetition is always good to re-emphasize concepts. So if it's too much of repetition, I apologize, but hopefully this will be useful to at least some of you in the audience. I don't have an outline for this talk. I have just random stuff that I'm going to be presenting, and that's what a potpourri is. It's really a mixture and a medley of different stuff. So let's go over some questions. The first question that often fellows will ask, largely because they're daunted by the idea of a bifurcation stenting, is should I go femoral? And as you just saw a case being done by Aaron, and certainly in our practice, the answer is almost never do you need to go femoral for a bifurcation case unless you can't feel a radial. And so all these cases can be done radially, even with a 7 French guide. The next question is that should I go 7 French? And Aaron has already sort of answered some of this. And, my answer is that if a 2-stent strategy is extremely unlikely, for example, the side branch is too small or the patient is just a bad candidate for a bifurcation stent because he or she can't take DAPT, then I think there's no need to use a 7 French guide unless, support is the issue and you need support. That's a different story. On the other hand, if a 2-stent strategy is either intended or possible, then I think in general, 7 French is preferred because you just have more real estate in the guide. You just makes life a bit easier. Having said that, if your lab only has 0.070 inch lumen 6 French guides, and I'll talk about this in a second a bit more. If you only have 0.070 6 French guides, then definitely go 7 French because these guides are just too tight for a 2-stent strategy. If, on the other hand, you have 0.071 lumen guides, then I would still say preferably go 7 French because it does get tight when you use these guides. But on the other hand, if you have an 0.072 lumen 6 French guide, you can stick with 6 French. And in our practice, we do a lot of DK crush through the 0.072 lumen 6 French guides. Now, what are all these? Well, these are basically internal diameters of guides. And the only 0.072 lumen guide that's out there right now is the Cordis Adroit series, and that's our workhorse guide in our lab. But there are other brands. So Cordis also has an 0.070 lumen guide. Most of the Boston guides are 0.070. And then the 0.071 lumen guides are the Medtronic, the Terumo, and the Asahi guides. And so it's important for you as a fellow to know what equipment you have in your lab and what's available, because surprisingly, this small difference from 0.071 to 0.072 makes a world of a difference in terms of how easy or difficult it is to do a 2-stent DK crush kind of strategy. Now, question 3, should I pick 2 wires or should I put in 2 wires? And the answer in general is yes, you should put in 2 wires. You should always wire the side branch. If nothing else, just to keep it open. If there's nothing else in your mind, it sort of keeps the vessel open even if there's plaque shift or carina shift. And the jail wire sort of changes the angle and it just acts as a marker and makes it easier to rewire if you have to. I would say most definitely, yes, you need to put wire the side branch if the side branch is important and has significant disease. And as you can see in the examples over here, up there, the vessel is small, and diffusely diseased. We would want a wire there just to keep it open. On the other hand, the down in the lower panel, there's a large, branch with a long sort of segment of disease. You definitely need to wire this because otherwise you might lose it and you may actually end up stenting it. Certainly, if the answer would be most definitely no, if the vessel is very small. So this if you look at it on the lower right panel, this little small diagonal, I would probably never wire that, although you should never say never. And then the answer can be maybe if you have a side branch that's very, very normal. Although for fellows, I will caution you, I will say, even if you have a normal looking side branch, if it's an important side branch, put a wire in there. It takes hardly any time. So please do that. The next question is, and this is something that's been asked and alluded to, should I use imaging, IVUS or OCT? And the answer is most definitely yes, if you want to, in order for stent sizing, to assess your landing zones, to assess plaque morphology, and certainly after stent deployment to look for expansion and dissection. I would also say probably yes, if you're trying to assess whether you need to do a 2-stent strategy. For example, if you have a side branch, it looks okay, but how okay is it? the imaging will help you assess how much plaque there is in the side branch. And if there's significant amount of plaque in the side branch, then compromise is quite likely, and your default strategy ought to be a two-stent strategy over there. The fact, though, is that if you see narrowing in the side branch on the angiogram, almost always the plaque burden will be significant or more than 50%. And, so just that's an important thing to keep in mind. The next question is, can I go provisional on a case? And the answer is, in general, yes, if the side branch is small or trivial, if the side branch ostium is normal, or the side branch disease is very short, like a very focal osteal lesion, but nothing else. In general, the answer is no to provisional if the side branch is large, or it has a long length of disease, or the side branch is very, very difficult to wire, because if it's difficult to wire now, it's going to be impossible once the stent is across. And then there's a sort of maybe group where maybe you can go provisional if the side branch, even though it's large, it is totally normal. In those kind of cases, you might be able to go provisional, but that's something that would be a judgment call, and that's where the learning process happens. But these are sort of general principles about when you can and cannot go provisional. And this is, for example, a case where we had an occluded circumflex as part of an MI. We opened it up, and then you can see that there's a bifurcation now that's now evident. But the upper branch is very normal, and we thought that at this point it was okay to just do nothing and just stent across it. And this is after we stented across it. So we made the judgment that even though the upper branch, the side branch was important and large, because it was okay to go provisional. What is the right way to? And the answer is that there are no standard or right way. So anybody who tries to tell you that there is one way to wire vessels is kind of making it up. The reality is you do whatever works. And, your creativity, comes into play, as well as a bit of trial and error. But the fact of the matter is that there are different kind of bends you can put it on the wire, and you put the bend that works for you. Keep in mind that the larger the bend, the less controllable the wire is. On the other hand, when you have a really challenging situation where it's difficult to get the wire in, for example, you have a very sharp angulation, as you can see over here. Then in that case, you have different sort of techniques to use. For example, you can use a balloon backstop technique that's shown over here to block the vessel so that you wire up here. Or you can use things like reverse wiring, double lumen. Just showing one example where we have a really odd kickoff of the diagonal. In this little panel in the middle, you can see that the diagonal actually goes up, which is an angulated microcatheter, used there to almost engage the side branch with supercross. And then once we were there, we put the wire in, it went in very, very easily. Moving forward, what is the right way to wire a side branch after you've stented? And this is something that Huay Cheem has addressed at length. Remember, for provisional, you want to get the distal strut, and cross into the distal strut, because you want to put the stent into the side branch. If you cross proximally, you will not scaffold the side branch. On the other hand, when you have a
So it looks like Fahim's broadcast is a bit jammed. So it's also good that we take a pause. Hao Bang, you have any comments on the talk so far? You're muted, Hao Bang. I can't hear you.
No, so far so good. You want me to comment on the case, or you just
no, comment on the so far the common potpourri questions.
Okay, yeah, I think those are great questions. These are the questions that our fellows ask, and even sometimes ourselves ask. I think the balloon, is he back? Sorry, is the balloon dilatation? I was asking, the choice of pre-dilatation balloon. How do you choose? Whether you use semi-compliant balloon, do you use non-compliant?
My apologies. I think I got disconnected.
Yeah, you're back.
My apologies.
Before you come back.
Yeah, maybe you can share and then we can just proceed. There
Yeah.
was some lagging from your wireless.
Yeah, I
think.
apologize. I'm not sure. I'm not exactly sure why.
No problem. We'll take your time. There's also questions from the attendees, which we'll ask the faculty later, which is for the port balloons, the side branch, post deal, and the kissing balloon. Does it necessarily have to be non-compliant balloons or just a standard balloon? So I guess we'll take that later.
Yeah.
So Fahim, you were at the wire.
So should I
slide.
continue? I'm happy to stop and we can answer the questions. Would you want me to stop?
No.
Or?
I think you should finish up your lecture. You're at slide 14. I think we lost you at 14. So two more slides back.
Okay, so basically I was talking about the right way to wire post-stent, and I was making the point that Cheem has already made, that for provisional stenting, you want to cross distally to scaffold the ostium of the side branch, whereas for a crush situation, you want to cross, you want to cross proximally and you want a non-distal cross so that you are able to expand the crush stent and the ostium is covered. Important to note that if your wire goes distal, then you will end up with, as you can see on the right-hand panel, you will have unstented ostium. And one sort of word of sort of tip for fellows is that if you end up crossing the side branch very easily with the wire, or very easily sort of say hallelujah and start inflating the balloon, just think that you might have gone distal and take the wire out and rewire, because you might be sort of, you might find that you enter the stent, the crush stent in a more better way. And the other thing that you can do is, which was I saw Aaron do this, is to cine the wire as it crosses and make sure that you have a non-distal, in other words, more proximal crush. Now, the reason why all this is important is because you then come to the idea, why do you need to do a part, or what's the right way to do a part? And Cheem has already gone over the benefits of the part, so I'm not going to reiterate that. It corrects under expansion. It allows you to actually push the stent into the side branch. And what do I mean by that? That's sort of illustrated here. If you just think of a tapering artery, and many fellows don't understand this, that what is the idea of part? If you think of a tapering artery, the way this corridor is, you have a distal vessel, which is smaller. You have a proximal vessel, which is bigger. You put a stent in, and obviously it's sized to the distal, so proximally it's underexpanded. So one purpose of part is to, of course, expand it proximally. That's easy to understand. But then if you think of a side branch that's up here, the other idea of part is to actually push this stent into the side branch ostium and actually scaffold the ostium. So you think of your part balloon as this guy who's kicking the door into the side branch. And what that then does is that it allows you to scaffold the side branch. And so if you look at this stent across the side branch, you have three different part balloon sort of locations. One is bad because you will overdilate the distal stent and you will carina shift and compromise the ostium. Two is not good because while it's too proximal, you expand the proximal stent well, the distal is already dilated, but there's no stent being pushed into the side branch. And three is optimal, whereas Cheem showed, the distal marker is right here at the carina. You push a bit of that stent into the ostium and you essentially scaffold the ostium. So that's the important point to sort of take home from this. The final question that a fellow would have is that what's the right way to do kissing balloon? And here we have two sort of examples of two bifurcations on the left and on the right. Now, you first of all have to have 1:1 sizing. So you can see that this balloon is similar on both sides, but the upper balloon is larger on the left and sort of smaller on the right. But then you also want to have the proximal markers sort of ending in the polygon of confluence. And then you do a low pressure inflation. And the reason why that's important is often people will do their kissing balloon with the overlap somewhere up here. The reason is because at the polygon is where the vessel is sort of largest and oval shaped. And when you have your two balloons together, it introduces ovality in the vessel. And we don't want ovality up here in the main vessel. We want it just limited to the polygon. So shorter overlap right in the polygon is important. And often I see people forget doing this. And of course, low pressure kiss, 6 to 8 atmospheres each. Final, last slide, what kind of two-stent strategy to use? I will say whatever you're comfortable with based on your personal preferences and skill. But I will say what not to use, and many of my colleagues may disagree with me on this, but I do feel strongly about T stenting. There's really no such thing as a real T. And if you try to go precise T, you will miss the ostium. So please don't do that. You just have to protrude in the main branch a little bit and do whatever you're comfortable with, whether it's a micro crush or a mini crush, DK crush, tap, or even culotte. And then the other stent technique not to use except in emergent situations is SKS. It's not a great technique except for when you have a real emergency. And basically, last advice to fellows is, hone in your technique, get familiar with 1 to 2 techniques, and sort of just practice them again and again and again, and you will do fine. All the best to you, and thank you very much.
Again, Fahim, congratulate you on this lecture. It's really very wonderful and very practical. And
my apologies for getting cut off.
No problem, not your fault. And it's very complimentary to Hui Chim's talk. Can I just get some comments from Professor Zhang about the question just now? For the port balloon and the side branch kissing balloon, do you always necessarily use non-compliant balloons, or can you use normal balloons?
Yeah, definitely. In terms of port or final kissing balloon inflation, NC balloon is a first choice. For me, I think it's a mandatory.
Any other differences in opinions here? Fahim?
In terms,
I think in DK crush, sometimes the first kiss I will do with a compliant balloon. If I try to do, I agree with what was said that as a general rule, always NC balloon. But sometimes the first kiss I will sometimes do it with the compliant balloon if it's just easier to get it in. But in general, NC balloons is the way to go.
Dr. Murasato?
Okay. In terms of kissing balloon inflation, the short overlapping is better than long overlapping kissing balloon inflation because long overlapping kissing balloon inflation causes a light cross. So the proximal part causes the more oval-shaped deformation. So the Dr. Jafary recommended the short overlapping is recommended. However, overlapping length is 3 millimeter. I recommend in my paper. And recently, Italian Lane Registry recommended the short overlapping kissing balloon inflation has a favorable trend, a favorable result compared to the non-final kissing balloon inflation group. So short overlapping kissing balloon inflation strongly recommend. And in terms of pot, finally, we perform the lip pot. However, lip pot position is very crucial. Lip pot position should be located more proximally because the regular position, cardiac distal marker at the cardiac site causes lip protrusion of the gel strut to the side branch ostium. So lip pot position should be located more proximally.
Thanks for that tip again. Dr. Natawat, is there a case where you do finish out with final kissing without report?
I think I always do final kissing with the NC balloon and report. I think it's important. And most we use NC balloon. The exception that we use semi-compliance is if I have like a vessel size is maybe like oval shape or maybe calcified nodule that I might not able to get the stent apposition that assessed by imaging well with because NC balloon, if the vessel is not in the circular shape, it's impossible that you can get a full apposition. So I think I might start with the NC balloon for pot, and then if it needs some additional stent apposition because of the vessel geometry, then semi-compliant balloon to achieve that. I think that will be my suggestion. But I think for kissing, I think NC to NC, if you can get it open, it's very important to keep the long-term results good stent patency.
How about any final comments or tips from you?
No, not so much of comments or tips. I just wonder the issues of the slippage of the balloons. You use a small balloon in kissing, sometimes we see the balloon slipped. I just wonder, what is your, take home, to overcome that? Because
Dr.
I
Chang?
hear that they tend to use shorter balloon. Well, I personally actually tend to like to use slightly longer balloon because I find that otherwise they tend to slip.
I don't think the balloon length is you probably use, average length 15 millimeter balloons. The important thing is that the proximal overlap should not be too proximal. So obviously, if your side branch stent is very short, then if you use a longer balloon, it's going to overshoot it. But most of these DK crush kind of cases are, long stents. So you can use a 15 millimeter balloon. I do agree with you that, a short balloon will slip, but the proximal overlap should be, the two markers should be at the polygon of confluence and not much more proximal than that. Otherwise you get this ovality, in which case repot, as Dr. Ratso said, is very, very important then.
So again,
other situation that we consider pre-dilatation kissing balloon.
So you do a kissing balloon before implanting a stent? Is that what you're saying? I'm not sure what you mean.
Preparation that we do pre-dilatation. When do we do, a kissing balloon?
Not routinely. The only time I do that is if I'm worried that the vessel is going to go down. So you dilate the LAD and the diagonal goes down. You dilate the diagonal and the LAD goes down. Then it's a good time to do a kissing in that situation, and then get on with the stenting.
So again, just to recap the points for fellows, I think we heard about all the strategies once you recross at the appropriate stent cell. So to recap, provisional distal, provisional distal, if you're doing a Keloid distal, if you're doing some form of crush, whether DK crush or mini crush, proximal, just be clear on that. Subsequently, I think if you decide a two-stent strategy, I think it's actually better to have some length margin, either proximal or distal, so you can do your kissing and final optimization comfortably. If you are too short a proximal and too short a distal, then you're caught with having very compromised short balloon seepage and all this other issue. I think there's very little downside to extending the stent length comfortably, so you can do your final kissing and report. And I think I take your point that we should snuggle a little bit closer and not overlap too much in the proximal segment when you kiss, and finish up finally with a report that doesn't cross the bifurcation. So these are some of the points. We're going to go back to the lab soon, but before we do, I want to, for the fellows' sake, share again the basic steps for DK crush. Again, we can discuss the bench model of what we mean by DK crush step by step, listening to what Prof. Zhang has said.
DK crush, a step-by-step guide. First, you will place the stent in the side branch and the balloon in the main branch. You inflate the side branch stent. Then, you will remove the side branch wire and you pull the main branch balloon back. Next, you will inflate the main branch balloon. If needed, you can place a bigger balloon in the main branch to further crush the side branch stent. Next, you will rewire the side branch and you do it in the mid or proximal. Then, you perform the first kissing balloon dilatation. Main branch is inflated, followed by the side branch at high pressure, followed by kissing balloon at lower pressure. Next, you remove the side branch wire and you insert the main branch stent. The main branch stent is inflated. And then you port the main branch stent with a larger balloon. Next, you rewire the side branch proximally. And then you perform the final kissing balloon dilatation. The main branch is first inflated, followed by the side branch at higher pressures, and the kissing balloon dilatation at lower pressure. And finally, you perform the final port. This is the final result of a DK crush.
Thanks, John, for demonstrating the bench model for us in a quick way. I think you saw there was actually quite a lot of steps. I think Professor Zhang says that definitely DK crush, but I think DK crush is a wonderful technique, and I would say it's not done as commonly because you saw so many steps. I think people are not comfortable with doing so many steps. If you do as a routine, I think it becomes easier and easier. I love the John Yap's demonstration, Professor John Yap's demonstration, but one step that the previous comment from the panelists brought up in this video is that I would have agreed with is when you deploy the side branch stent before you crush, I usually put in another appropriately sized NC balloon to really open up the side branch carina first before I crush with the appropriate size main branch stent. So that's one step that in John Yap's video, it wasn't quite shown, but he showed everything else perfectly. So Professor Zhang, any comments on the bench model that John Yap did?
Yeah, it's an excellent bench test for DK crush. And also I agree with your suggestion after side branch standing, you'd better use NC balloon to post-dilate the ostimal side branch in case of stent on expansion. And another comment is about the final case ablation. I think the overlapping lengths are a little longer. So maybe shorter is better, maybe 3 millimeter, maybe better. Avoid too longer inflation where induced the balloon. I think the proximal stent distortion.
Thanks, Dr. Zhang. John, you have any comments about your demonstration?
No, I agree with the pointers, sir. In clinical practice as well, I usually post-dilate the stent, side branch stent in this case, before we crush it, so to ensure optimal optimization.
Okay, so I think it's time to see whether Aaron is still struggling. So let's go back to the Cath Lab. Obi-Wan, can we switch back to
if you can
Cath
put
Lab
the
now?
diagonal wire down a bit.
We can share now. Aaron, we're back to you. Wow, it looks very nice now. Wow. So we miss out a lot of action.
Cannot show you first. Yeah, we Chiten very nicely rescued the situation. Okay, we'll start from here.
Okay, it's okay to just start from the beginning.
OCT from the diagonal first, and then we will tell you the whole story. We finish after we did the diagonal, huh? Okay. So we did the finish the procedures. We're going to do the OCT from the diagonal.
So why don't you finish up the OCT?
Done, yeah?
We can watch the OCT live. Then you can, in the last.
Can you up the volume, please?
Yeah, Aaron, it's okay. You go ahead and do what is required. You show us a final OCT to the diagonal. You can look at it live. Chiang can comment. You can prepare.
Okay, ready?
Show us from the beginning.
Louder. Okay, come.
Is that as far as you're going? Okay. Yeah. I have no.
Yeah. Midway from the stent. Yeah.
All right. Small test.
Yeah, so it's good that you're doing more OCT because Nata would say you must use up the money's worth, you know.
Okay, get it. All right, Sini, check.
So this, we didn't go very to the distal part of the stent because there's no landing zone for the nose cone. Yeah. Okay.
It's okay on the Sini, it's not me.
Okay, can we see the OCT now? Obi-Wan, let's switch to the triangular view.
Go back to where we.
Let's have the OCT as a major view. Maybe then Chiang can do a live commentary on it.
You want to do that now, or go according to the sequence of events? Because
okay, so let me just see how Chiten actually save the day.
Then do you mind we switch back to floral first?
Okay, so when we left, let me see where we are. Yeah, it was here.
Trio.
It was here. Yeah, the trio actually, we did the stent boost and realized that actually the diagonal wire actually went into the stent struts, not across or sideways to the stent strut, and the LAD wire actually crosses the first struts of the diagonal stent. So we didn't know it was inside. It looks a bit like it's crossed the stent, but we say with no choice. So we actually deploy that. Crush the stent again, and then we use a stent boost. I'm not sure whether I can put the stent boost on the thing. This is clearly that we cross the first stent straps of the diagonal stent.
So Aaron, can I just ask then, did you rewire or you converted this to a string Keloid technique in the end? Or
no. This is the string is only the first part. It didn't actually far enough at the diagonal to call it a string. So it's like it's just an inadvertent sort of rewiring of the side. We didn't cross to the main branch. The main branch actually crossed one of the stent straps of the stent. Not this one. Back. Can you go back? Yeah, this is the one. Next one.
OB Van, can you switch to the stent boost for us to have a look? So the stent boost is a useful technique here to see.
No, next one.
Next is in previous. Oh,
no.
Forward
one more. Forward.
I can't see the.
Yeah, here we go. Can you see the stent boost?
Yeah, now we can see.
Yeah.
So you're saying that we are through the proximal stent strut, right?
Yeah, correct. Yeah. So fortunately, this onyx stent, actually the side hole from the stent strut is even the 2.0 stent actually can go up to about 3.7. Yeah, so it's good enough for us to put a 3.0 stent through the stent strut without distorting the stent structure. So continue on. So we recross the diagonal. So this time we make sure that is cross the right stent struts, and then
meaning more proximal and mid stent struts.
Yeah, mid proximal, and then actually go through the stent strut rather than through the stent. Yeah,
across the crushed area. Before that, we went in
at the
into the lumen. Yeah,
in the entry area of the thing. Yeah. So the 1.0 balloon, 1.5 balloon crossed very easily without any problems, and then we use a nitro. This is we do a first kiss. Here's 2.5, 3.0, and then the first kiss, and then we did the OCT.
Yeah.
Okay, Chia, okay, look. We want to see the stent straps to show the
So you had first kiss, then you had the OCT and the LED after the first kiss. Is that correct?
Yeah, correct. Yeah.
Okay, so we can see the OCT. So this is OCT of the LAD after the implantation of and crushing of the diagonal stent. So just looking at the part where the diagonal stent is crushed. So diagonal coming in in this case from the 6 o'clock position, you can start to see some stent straps. Here, everything seems to be crushed towards the bottom, the 6 o'clock region. But just here, you can see that there are stent struts around the wire, around the OCT catheter and around the wire. So that is consistent with what the stent boost showed, in that the wire probably went into the very most proximal strut of the stent and then exited back out and crushed the rest of it. So that's why it's got this appearance. So it's like.
Can I get some comments on from Dr. Muhammad Sato about this?
Yeah. Could you show the 3D OCT reconstruction? Can you perform the 3D OCT reconstruction? When we get such kind of images, we can identify the accurate recursion point.
Bring a stent onto the picture.
Mm-hmm.
Yeah, because we just interested to see that
enlargement.
That part. So we didn't actually only a certain part of the stent
most proximal part. Yeah.
It looks going into the proximal part of the vessel.
Yeah.
Yeah.
Maybe the guidewire cross the most proximal part of the onyx stent. Onyx stent, smaller cell clustered in the most proximal side. So maybe this guidewire enter into the most smallest cell in the proximal spot. So Dr. Long performs the guide wiring to the second cell. So that is a good option for the good opening for the side branch, probably.
And
so
I see
actually,
that
there is an option of pulling out the wire and rewiring it, but we thought it may be a bit difficult because the diagonal the sensor is already sort of flared out, so maybe a bit difficult to wire. So we just think that just opening out the first cells should be okay, because this is Onyx Stent. It allows a very big side cell extension.
Any comments from the rest of the panel at this juncture?
I was going to ask the question that Aaron just answered. I mean, why not just pull the wire and try to rewire?
Yeah, there is an option. There is an option, but the thing is, you may not know that you entered in outside the stent shrouds, so a bit difficult. Yeah, even though Onyx is very radio opaque because of the core iridium inside. So, but it's still a little bit difficult to see. But anyhow, so we just forward, and then we put the 275 38. 275 38. Can you show the float? From the OCT, we thought was a bit short, but we're going to just land it just right at the pouch there. Hopefully, if it's not enough, then we will just put one more stent distally to cover the distal part. So we deployed it, and then we potted with the 3.5. This time we learned our lesson, so we deploy really big high pressure, and then recrossing the side branch is not an issue. And then 1.5 and then 2.5 post dilate the diagonal stent, and then 3.0 dilate the LED stent, and then we did the final kiss.
Aaron, how much of a length did you have proximal to the diagonal with this with the LED stent?
Probably just about right.
Quite
about
short,
8.
right?
Yeah, about 8. So the 8mm NC balloon just got it.
Okay.
So
I think for fellows that's important, that point that you need to have enough length proximal to the bifurcation to do a part.
Okay, so we do the OCT from LED. Yeah, Xian, thanks.
Yeah. So OCT. This is the I guess final OCT after post dilatation. So this time let's go from distal to proximal. This is the distal. This is distal to the stentage. So as the operators alluded to, the stent was maybe slightly short, but so it landed in a little bit of plaque, but there's certainly no distal edge dissection or anything there. So this is the stent. It's relatively well expanded. Everything's opposed. Here we come to the bifurcation point. There in the 4 o'clock position, there's the side branch wire coming in. And this is the proximal stent edge again. Everything is quite well opposed. Yes, just out of curiosity, we can have a look at the 3D reconstruction as well.
So looking at this image, is there a need to report or after the final kissing?
I guess it looks a bit elliptical. I don't know whether reporting will make everything more circular or not.
I noted your proximal stent is a bit short. Any advice from the rest? Prof Tan, Hui Cheem is back with us. Hui Cheem, is this what you imagined before you left? What the final result?
It looks pretty good actually. But one of the comments about kissing balloon inflation is that nowadays we would like to park the balloon in a manner where the proximal end of which is right at the carina, and then finishing it with a short balloon, single balloon for port. So instead of having the 2 balloons extending all the ways to the main vessel, you want to just park it at the carina and then finishing it with a short, a larger balloon. The reason is because of, I think, Dr. Fan's study. I think when you have 2 balloons going in, you create more ellipticity than the circularity here. So, but I think based on the OCT, it looks pretty good here, result. So I'm not sure whether a port is going to make a lot more difference.
Thanks for re-emphasizing the point that previously Fahim presented and Dr. Chang also concurred for fellows' part about a shorter confluence kissing before a report. So can I ask the rest of the panel, based on this OCT result, would you like to do anything different now at this point? Dr. Natawood?
And could you
Yeah, I
show
think looks okay. On the axis, on the upper right hand side, can you change the axis of the vessels so I can see the bifurcation on the other one? Yeah, that one. No, the top right. And you change the axis so I can separate the bifurcation. Yes. Okay, this view. Okay, and then you can and you can measure the length, because I think this looks good, and you can just go forward and backward.
Dr. Murasato?
Because the bifurcation, I think it might not be enough room for pot, but I think the up position, it looks okay to me. Yeah, and the vessel is open, it looks good.
So Carina, so double layer Carina should be identified of this view. However, maybe a red strut is a metal Carina, however, single strut. So I wonder what happened. So could you show the side branch diagonal pullback?
Diagonal pullback as well.
Yeah, maybe.
Yeah. So
diagonal pullback.
So the crash at the Carina side has a risk of the side branch Carina side crash. I fear. So could you show the side branch pullback?
This is the side branch pullback.
Okay.
This is the diagonal, yep.
How about, at the ostium? Okay. Yeah, fully covered. So overlapping sides is very minimal.
So Dr. Murasato, can you tell us and the fellows what exactly are you looking at in terms of OCT for suitable coverage? What were you looking at?
Yes, for the OCT, especially in the bifurcated area, stent malabsorption is very important. So stent malabsorption should be within the 400 micrometer. So according to this view, there is no significant malabsorption area, and metallic carina should be located in the neutral position, because carina should be act as a flow divider, so should be located as a neutral position. In this view, the metal carina is located at a minimal and located as a neutral position. And the OCT view, the expansion for the OCT expansion index is ideally larger than 76%, but this side branch is 73%, but it is acceptable.
So for the final adjudicator, whether this DK crush technique is well done, I'll ask Professor Zhang to say whether this is a pass or fail.
60 points, I think. Or fail, yeah.
Prof. Zhang Junjie, what is your final comment? This is okay or not okay for DK crush? You're muted, sorry. Is it possible for you to unmute yourself first, Professor Zhang?
So I think the sort of mistake or the thing that we actually made is actually we lost the main branch access at one time, because when we pull back the 3.0 crush balloon, somehow the balloon stuck to the wire. So when you pull back the balloon, the LED wire actually came out. So the main advantage of DK crush is that you will not lost the access to the main branch actually. So in this case, actually, we inadvertently pull out the wire. So that is what happened when the wire is pulled out. So when we rewire, so it's not it's sort of wire into the stent. Yeah. So
I think it's a great result, Aaron.
Yeah, actually, to mitigate that, maybe we should have crushed with a bigger balloon. So yeah. So actually, the crush actually is very important. So big balloon, good crushing, that helps to bail out if this kind of situation happens.
There's two last finishing grade points, but I think this is a very nice result. Prof Zhang's mic couldn't be unmuted, so he can't tell you whether he give you a 60 marks or 80 marks, but it looks good to me.
D minus, I think. D minus.
A minus, okay. So it's the last 10 minutes of our session. I'd like to thank the operators for doing such a wonderful case. I'm going to go around our panelists for them to deliver their last teaching point for fellows before I summarize. So we'll go for Dr. Nuttlewood first.
Thanks for wonderful case demonstration. And I think for the fellows, I think for bifurcation, then 70%, I think we can easily doing with this provisional stent with kiss pot. I think that will be a simple spray. But in the patient, I think you need to know the definition criteria. I think with the definition 2 criteria, I will demonstrate that when the patient need to stent, I think they have to go to stent. You should not go with provisional and switch to stent. I think it is much more difficult. And for 2 stent technique, is many technique you can achieve. You just know what advantage and disadvantage, what limitation on each one, and you familiar with it and try to do it and stick with it. And once you familiar with one, you can add on with other and more, but just be familiar with it. So the key message is provisional 70%, and if you need to, go to.
Thanks, Nuttlewood. Fahim?
I mean, I think everything's been said, and I think it's important to keep conceptual basis of what we're doing in mind. So everything has a conceptual basis. So just think the case through. The only tip for today that I have is when it's critical, and the 2 situations that come to mind is when you have a dissected vessel or when you have a crushed stent. Be very wary of the wire, and if you're pulling a balloon out, do it under floor so that you don't lose the wire. That can be a very important problem if it happens. So these are experienced operators, Aaron and Chiang. I mean, they can salvage anything, but for junior operators, that can be a devastating problem. So just keep your eyes on the wire.
So don't lose your wire. Hao Bang, your finishing tip.
Yeah, I think I always say this: is 80% planning, 20% doing. So like all techniques, whenever we teach all our fellows, including ourselves, is a lifelong process of learning. New techniques come along, new technology comes along, and I think we all have to be humble, to always plan well. And even with experts, you can see here, we have the experts showing it. Things sometimes can still go unplanned, but they're able to salvage. And then I think that is the most remarkable, in experienced operator. So I think fellows practice, but safe. Practice in the safe patient. Don't pick the sickest patient to start with. And I think when we do these things, it's good to have, proctors and people beside us hold our hands until we are truly independent before we move on to the really tough patients.
Prof Tan, your one teaching point.
Well, I just want to echo the fact that PCI process is a very dynamic one. You can plan everything you want, and the unexpected can happen. So go back to the first principle and deal with it in a cool fashion. I just want to comment on overstretching of a cell space. While the likelihood of a stent disruption, architectural disruption is unlikely, but if you stretch a cell too big, more than what it is meant to be, you wonder about the polymer integrity as well as the drug illusions coming up from there. So I think that will be something that you want to bear in mind as well.
Thanks, Prof Tan. Sensei Murasato? your teaching point?
Oh, actually, there is actually the complex case which requires two stenting. Especially in the complex bifurcation region and the left main ACS case. So in such case, we should perform the complex two stenting. So we should know the step by step. We should know the step by step. Yeah, that is important.
So know your steps and be very meticulous. Dr. Zhang, the Cath Lab gave themselves A-. You'll be the final grader here. Well, what is your final teaching point? Your grade to our Cath Lab here.
So I think bifurcation lesion strategization for majority of simple bifurcation, I think provisional stenting is the definition default approach. However, for complex anatomy, according to the definition criteria, two-stent technique, DK crush is my favorite. And also for left-main stenting, I think intracoronary imaging guidance is mandatory, either IVUS or OCT. From the imaging, we can facilitate stent sizing and also optimizing the stent result. Thank you.
Thanks. I think you probably did the summary for me, Prof. Zhang. You haven't given Aaron his grade yet. Based on his result, what is this a passing grade?
Yeah, I think the final result is quite good according to the angio or OCT result. It's although there is some stuck during the procedure, but the final result is fantastic. Congratulations.
Okay, so thanks a lot. I just give a quick summary for fellows. Again, today's session was on bifurcation and DK crush. Firstly, bifurcation summary 1, provisional is suitable, is great, but please do learn to do it properly with a proper port, side branch protection with whatever means to keep it open and to bail and do a rescue technique if needed. If you, based on the current evidence, I think if it's truly a complex bifurcation, a two-stent strategy will give better results. Do get familiar with one of the techniques. Today's session was on DK crush, but any technique well done should be all right in my mind. In most of the bifurcation technique, I think the port before any crush or anything, it will be the most important part. I think a properly sized port is, in my mind, crucial. And I think the DK crush again has various advantages. The biggest advantage is that it's built into the technique that the side and main branch are properly optimized multiple times in the port maneuvers. And of course, the main branch wire is never removed, so you always have access to the main branch, which sometimes can be the lifesaver. So with that, I want to thank the Cath Lab for doing a wonderful case, for 2 lectures that was complimentary and put in different ways, but wonderfully done as well. And for our panelists for their wonderful comments and attendees for spending Friday afternoon with us. Do catch us next for a subsequent webinar. Sorry, John, you came in last, so maybe our fellows in attendance can have the last word. Anything on the fellows' behalf?
Having been a fellow recently, I think the most important thing that I would like to mention is like practice. I mean, there's nothing that beats, you can read and you can watch all these webinars, but it's good to take home pointers, but you need to try it yourself. And you just need to keep practicing, and then you'll be more comfortable with more experience.
John is too humble. He's practiced a lot. Okay, good. Thanks a lot, guys. So do keep safe. I'll catch you soon for our next session. Thank you and goodbye.
Thank you.
Bye-bye. Thank you.
Bye-bye.